What's up, everybody? How are y'all? Hope everything's going good. I'm going to do little things a little different. We're going to do a recording so you guys can watch this and while we get some other things taken care of, but we're going to go over respiratory emergencies right now. So we're going to talk about medicine that applies the fundamental knowledge to provide basic emergency care and transport based on assessments, finding, and the actually acute ill patient. We're going to go over the anatomy, signs, and symptoms management, respiratory emergencies, including those that affect the upper airway and lower airway. We'll go over the physiology, pathophysiology, basically what to look for, how to recognize anything that has to do with epiglottitis, spontaneous pneumothorax, which we've talked about before, pulmonary edema, and we'll talk about asthma, chronic obstructive pulmonary disease. Just making sure everything's good on the recording, sorry. We'll go over environmental industrial exposures, talk about like working in type of plants, any type of chemical exposures, how to identify that, any type of toxic gases, bursitis, cystic fibrosis, pulmonary and embolisms. We'll talk about the pneumonia, or the viral respiratory infections. So obviously, as we go through this process, we know that we're going to be responding to several things that affect us as responders. We know we're going to see all these things. Dyspnea can be caused by many different things, and that's the one or two word dyspnea, and I've showed that before. It's like I'm having trouble breathing, into those effects. Even without a definitive diagnosis, you may still be able to save the patient's life. And just providing oxygen, we've talked about before. So supplemental oxygen is our biggest thing. We want to give them, and we don't want to ever withhold the oxygen. So the respiratory system includes all the structures that contribute to breathing. So remember when we've gone over the upper airway, the lower airway, the right and left main stem, and the lungs. So now we talk about the diaphragm, the chest wall muscles, accessory muscles to breathing, and nerves from the brain and spinal cord to those muscles, and how they all intertwine and affect each other. So we talk about the nose. So the upper airway, again, let's go back over this, consists of the nose, the mouth, the jaw, the oral cavity, the pharynx, and larynx. So here's a picture so we can go back over this and refresh. We talk about the upper airway contains the pharynx, mouth, epiglottitis, and the larynx we said before. Then we go down into the lower airway. We talk about the trachea, the the bronchioles, and the main bronchi. Now, remember when we talk about down in here, we've broken this down before where it breaks into the alveoli, and you have your pulmonary capillaries because the blood's going around the capillary. So, and that's just how the blood flow is broken down into those areas. Just as a refresher, kind of remember this picture of the difference between the upper and the airway, upper and lower airway system. And they're going to ask particular questions, is the trachea divided into for the lower airway? So those may be some of the questions you see. The principal function of the lungs is the respiratory. So the exchange of oxygen and carbon dioxide. Air travels through the trachea into the lungs, then into the bronchi, bronchioles, and the alveoli, this should be a little bit of a refresher before we've talked about this. So we know that this is something a little different. We're just going to dive off a little bit more specifically into the respiratory system. And so there are two processes that occur during respiration. We have our inspiration, which we're breathing in. We have our expiration, which is the passage of pushing air out. Oxygen is provided to the blood and carbon dioxide is removed from it. So they clean it. It's going to scrub it, clean it, and send it back out. It's just basically like a dialysis machine. So when we breathe in, we're breathing in clean oxygen, and we breathe out, we're pushing out carbon dioxide. And a healthy lung is the exchange of gases takes place rapidly at the level of the alveoli. So we know our overall point of inspiration and expiration is clean oxygen, and then we push our carbon dioxide out. So the figures here show a close-up of the exchange of oxygen and carbon dioxide with the alveoli. So you see how the blue is the clean coming in, red's go. And this is the exchange of oxygen and carbon dioxide into the tissues. Breaks down over here a little bit further. You see how the blood cells, capillary nutrients pushing in, and then you got the carbon dioxide and the waste coming out. So we make sure that we know the process from the bronchiole and the capillaries here, brings clean oxygen or clean blood, dirty blood, change here of the carbon dioxide and oxygen. let's see here. All right, so the alveoli lie against the pulmonary capillary vessels. So oxygen passes freely through these tiny passages in the alveolar wall into these capillaries through the process of diffusion. So we're going to talk about diffusion, and diffusion is carried to, it is carried to the heart, which pumps the oxygen throughout the body. So carbon dioxide now returns to the lungs and is exhaled out of the body through the respiratory system. Breathing in through your mouth or nose, and you exhale. Same. The brainstem senses the level of carbon dioxide in the arterial blood. If the level of carbon dioxide drops too low, the person automatically breathes at a slower rate and less deeply. If the level of carbon dioxide rises above the normal, the person breathes more rapidly and deeply. So what we're trying to do is the body automatically senses that, and we're like, okay, we need to keep that level low or keep it, or we need to off it. And so the body, it's automatic, it's an involuntary system that adjusts our respiratory rate and how we breathe. So that process, we don't have to think about it. We don't have to make it happen. It just does it on its own. The proper exchange of oxygen and carbon dioxide can be hindered by several different things. So we have an abnormal or pathologic condition in the anatomy of the airway, which consists of like diseases. We have trauma to the area and abnormalities in the pulmonary vessels. So several different things can affect the way that our exchange takes place. But if we can fix that by supplying supplemental oxygen and assist into that, like we're gonna apply that oxygen. So the EMT, we recognize these few things so we can try to fix that. So recognize the signs and symptoms of inadequate breathing and know what to do about it. How are you going to fix this? So carbon dioxide retention and the hypoxic drive. Some patients will sometimes have an elevated level of carbon dioxide in their arterial blood. So we're going to check that using our pulse ox. That's one of our tools. If levels remain elevated for a period of years, the respiratory center in the brain may not function properly. It's going to be a little bit slower. The brain gradually accommodates high levels of carbon dioxide and then uses a backup system to control breathing based on the low levels of oxygen. And this is called the hypoxic drive. Use caution when administering oxygen to these patients. And the reason why they say that is this is long-term delivery of oxygen, like we're in there. So us providing 15 liters of non-rebreather is not going to force a hurt this patient unless you're on a long extended transfer from hospital and you realize that you do your assessment and you're reading the patient reports and all that, and you realize that they suffer from low oxygen. We don't want to provide high flow O2 for a long period of time. Some causes of dyspnea. Dyspnea can be caused by many medical problems. Altered mental statuses may be a sign that the brain is hypoxic, which means it's low of oxygen. Patients often have difficulty breathing and or a hypoxia, which is the following medical conditions. You have pulmonary edema. You may suffer from hay fever, pleural effusion, obstruction of the airway, hyperventilation syndrome, environmental industrial exposure, carbon monoxide poisoning, or drug overdoses. Be aware that one or more of the following situations may exist in the dyspnea patient. So you may have issues with gas exchange between the alveoli and the pulmonary circulation. Is obstructed by the fluid in the lungs. So they may have like a buildup of fluid. They may have COPD. They may have their skin may be swollen from, or they just may basically have a couple alveoli because over time they fill up and they're worn out. They're not going to work because they're filled up with other, let's say, carbon dioxide. They don't get a good exchange. The alveoli are damaged and cannot transport properly across their own walls. The air passages are obstructed by muscle spasms, mucus, or weakened floppy walls. Blood flow to the lungs is obstructed by blood clots. The pleural space is filled with air or excessive fluid, so the lungs cannot properly expand. And back into this one, reason why also here is damaged alveoli too is we may be a long-term smoker, and those alveoli are damaged due to the smoke itself. So we have to be cautious about that and realize that they may be in that hypoxic drive on a long period of time because of being an extended smoker. So here's one of the tables on 1016 that shows symptoms of inadequate breathing. Y'all can check that out in your book real quick. I'll give y'all just a second to pause and look at that. All right, dyspnea is a common complaint in patients with cardiopulmonary disease, so that's COPD. Congestive heart failure causes the heart to pump inefficiently and deprives the body of oxygen. A severe pain can cause a patient to experience rapid, shallow breathing without the presence of a pulmonary dysfunction. So this is probably going to be our sign. The reason what they call this for is pain with rapid breathing. It's what they sound like because they can't get deep breaths anymore, and it's very painful when they breathe. So the upper or lower airway infection. Infectious diseases cause dyspnea and may affect all parts of the airways. Oxygenation is a problem of inadequate oxygen delivery to the tissues. So they can't get the airflow. We can't get that exchange. The proper cause of dyspnea is always some form of obstruction. Again, we're going to have mucus or secretions obstructing airflow in a major passage. So you may have a cold or diphtheria. Swelling of the tissues in the upper airway, which include epiglottis or croup, impaired exchange of gases in the alveoli, like pneumonia. Be diligent about the use of proper PPE when conducting with patients who have infectious diseases. And remember, infectious diseases, we have to make sure we have all of our PPE on because it's passed on by air droplets. So croup is an inflammation and swelling of the pharynx, larynx, and trachea. This is typically seen during the 6 months and years of age. Hallmark signs of croup are stridor and a seal bark on the Croup often responds well to the administration of humidified oxygen, and we need that to be humidified. Sometimes some ambulance services don't carry that. We get a good exchange that due to humidified. They helps them breathe better. Like if they have a humidifier in their home, it helps them breathe a little bit better too. So remember, croup and virus, that is a virus infection, versus epiglottitis is an infection. So that's how I reverses those number of letters, and that lets me know that croup is a virus versus epiglottitis is a virus. I mean, is an infection. Sorry, just added that little tidbits in there. Epiglottitis is an inflammation of the epiglottitis of the epiglottis, usually as a result of a bacteria infection. See, there we go. It's more predominant in children, but can occur in some adults. Children are often found in the tripod position and drooling. The tripod position, remember, is because they're leaning over, supporting their body against something because they're allowing the gravity to help pull their chest away so they can take deep breaths. They're drooling because it hurts to swallow. You have that raw, sore, nasty part of their throat that just don't want to swallow. Treat them gently and try not to make them cry because that's going to be very painful. Position comfortably, provide high flow O2, and do not put anything in their mouth. Don't encourage them to try to swallow or suck on this lozenge or anything like that because that's just going to potentially create an airway obstruction. So respiratory, or sorry, RS, I was looking at something else. I apologize. So RSV is a common cause of illness in young children. These common causes are infections in the lungs and breathing passages and leads to a bronchiolitis or pneumonia. It is very highly contagious. So be cautious on that. Assess for signs of dehydration and treat airway and breathing problems. That is one of the things that we have that are, we want to treat this humidified oxygen, again, is very helpful. And always treat the airway with breathing problems. We know that our ABCs fall into the issues there, so we have to treat their breathing problems. And look for signs of dehydration to where they just look like the bagginess underneath their eyes, or they have just the droopy skin because their overall body is dehydrated. Bronchiolitis is a virus that occurs due to RSV. And it usually affects newborns and toddlers. Bronchioles become very inflamed, they swell, and they have a lot of mucus stuffed in there to them. You want to provide oxygen therapy and frequently reassess for signs of respiratory distress. Now, remember, these babies, when they start to have respiratory problems, they will decompensate very fast and they will. Right. So in pneumonia, a general term that it refers to an infectious infection of the lungs. This is often a secondary infection that begins after the upper respiratory tract infection. So I think I had some issues there. So assess temperature to determine presence of fever, provide airway support and supplemental oxygen to all the patients. They're struggling to breathe no matter what. So that's our main concern, is to make sure that we can get them to breathe better. We want to open their airway the best that we can. We just have to be very gentle with people with pneumonia. We don't want to cause any other respiratory issues. That's why we want to always make sure we provide oxygen to them. Bursitis or whooping cough is an airborne bacterial infection that mostly affects children younger than 6 years old. Patients will be feverish and exhibit a whoop sound on respirations after a coughing attack. Highly contagious and is passed droplet infections. Watch for signs of dehydration, and suction may be necessary. So if they have a lot of mucus or a lot of saliva coming from their mouth, let's just try to help clean them up. Just up and just make them feel a little bit better. Just providing that little bedside manner can help out a lot. So influenza type A, the way that we figure out and get our flus for the year is we base our flu on what Australia has the season prior. So we know through COVID, number has been super drastically down. So we don't know what type of flu we're going to have this year. So influenza type A is an animal respiratory disease that it has mutated to infect humans. So transmitted viral direct contact with basal secretions and aerolized droplets from coughing. So we know it's passed from person to person by coughing and just not washing your hands. Symptoms include fever, sore throat, cough, muscle aches, headaches, and fatigue. Everybody's had the flu at some point in their lives. And this may lead to pneumonia or severe dehydration because we just don't feel like drinking. We don't want to mess with it. So we talked about COVID again. I think we're all an expert on COVID, so I'm going to skip over that. Tuberculosis or TB, we did dive into that a little bit last night, or just the other class. So we'll just dab just real quick. TB is a bacterial infection that commonly affects the lungs, but it also can be found in almost any other organ. It can remain inactive for years before producing any symptoms. Patients often complain of fever, coughing, fatigue, night sweats, and weight loss. If you suspect your patients to have active TB, you need to wear a mask at a minimum and always put a mask on at the patient too. Acute pulmonary edema. I would say that word got me. Sorry, y'all. So the left side of the heart cannot remove blood from the lungs as fast as the right side. So we know that there's a buildup of fluids in the alveoli and the lung tissues. So usually it results from congestive heart failure. These patients normally have CHF and have had it for a while. Patients usually experience dyspnea with a rapid, slow shallow respiration. Sorry, it should be rapid, shallow, not slow. In severe cases, you should see a pink frothy sputum at the nose and mouth. That is highly contagious. That is lung tissue. If you see any type of pink sputum, be cautious because that's lung tissue. Most patients have a long-standing history of chronic congestive heart failure, and it can be kept under control with medications. Not all patients with pulmonary edema do have heart disease, so don't let that fool you. So if you see pulmonary edema and swelling around the feet, don't just assume that they have heart disease. So right here, we talked about again, the fluids right here built up into the alveoli of the pulmonary edema here. You start to see this, and they sound like they're breathing through a bubble. You hear when they breathe, and you listen to their lungs, it sounds like they're gurgling. Those lung sounds, again, I encourage you to Google that and listen to the different types of lung sounds. That's the best way that I can think about teaching you virtually this way. So chronic obstruction pulmonary disease, we'll refer to that as COPD. So a lung disease characterized by chronic obstruction of lung airflow that interferes with normal breathing and is not fully reversible. So the umbrella term that we use to describe a few lung diseases include emphysema and chronic bronchitis. So tobacco smoke is a bronchial irritant and can create chronic bronchitis, and ongoing irritation of the trachea and bronchioles. So with bronchitis, excess mucus is consistently produced in its obstructive small airway and alveoli. So airways are weakened, and the productive cells and lungs, mechanics that remove foreign particulars are destroyed. So we don't have that ability to do that anymore. So chronic oxygenation problems can also lead to the right heart failure and fluid retention. Pneumonia develops very easily. Repeated episodes of irritation and pneumonia cause scarring the lung and some dilation of the obstructed alveoli, leading to COPD. So emphysema is the most common type of COPD. Emphysema is the loss of the elasticity material in the lungs as a result of chronic stretching of the alveoli. Smoking can directly destroy the elasticity of the lung tissues. Most patients with COPD have elements of both chronic obstruction of chronic bronchitis and emphysema. Now, we don't know, we haven't had it around long enough to figure out what the results are going to be of long-term vaping, but I'm pretty sure we're facing with regular smoking. Here we talked about, this is the how COPD affects the alveoli. We look here, the alveolar sac. This is a normal one. We have trapped air to here, and this is an obstructive lung. See how massively swollen it is? These are all dilated, and it's causing issues there. Lungs versus dry lungs. Patients with pulmonary edema, caused most often by congestive heart failure, will often have wet lung sounds. Rhonchi or crackles, and the patient with COPD will often have a dry lung sound that's created by wheezing. Do not assume that all COPD patients have wheezing and all congestive heart failure patients have crackles. Treat the patients, not the lung sounds. If the patient's complaining, fix that, not what your assumptions are. Remember, don't form assumptions. Asthma, hay fever, and anaphylaxis. Asthma and hay fever and anaphylaxis result from an allergic reaction to an inhaled, ingested, or injected substance. So that breaks it out. Here's a picture of the, you see right here, we have mucus obstruction bronchioli. So that is a narrow, this is our normal passages of the airway. So an acute spasm of the bronchioles associated with excessive mucus production and swelling of the mucus lining of the respiratory passage. So here you see how it's already swollen, it's aggravated. Now we have mucus that's lined in here, and then we're unable to get that out of our way. So this does affect all ages, as most of the time is prevalent in between children and 15 to 17 years old. It produces a characteristic of wheezing as the patient attempts to exhale through a partially obstructed airway. An acute asthma attack may cause by an allergic reaction to specific foods or some other allergen. Attacks may be caused by severe emotional distress, exercise, and respiratory infections. In its most severe form, an allergic reaction can produce anaphylaxis. And anaphylaxis can be fatal. So keep that in mind as we go to treat these patients, that they can crash on us very fast because we see them at the latter part of the stages. So hay fever, or just as an allergic rhinitis, it causes a cold-like symptoms, includes a runny nose, sneezing, congestion, and sinus pressure. Symptoms are caused by allergic reactions, usually to outdoor airborne allergens. Can be pet allergy, can be grass, could be all sorts of things. But your anaphylactic reactions. So here is a severe allergic reaction characterized by severe airway swelling and dilation of the blood vessels all over the body. This may be associated with widespread hives. You may have itching, you'll have signs of shock, and signs and symptoms similar to asthma. The airway can swell so much that the total obstruction is possible. Epinephrine is the treatment of choice, and oxygen and antihistamines are very helpful. All right, so spontaneous pneumothorax is a partial or total accumulation of the air in the pleural space. I'm going to show you a picture in a second, make it a whole lot better. It is most often caused by a traumatic event, but may also be caused by medical conditions such as spontaneous pneumothorax. So here's our picture. As you can see in the picture, hold on one second. So now that you can see this, you can see that we have the pleural spaces up here, and then we have our pleural, the partial pleural, sorry, and then the pleural spaces here is the light purple. So this is our wound site right in here. As you can see that there's a hole, and then we have our visceral pleural with our collapsed lung, because this is the affected side. So now that all this air is getting trapped right in here in this pleural space, that is not what we want to see. That is a spontaneous pneumothorax. Breath sounds can be absent or decreased in the affected side, and it has the potential to involve in a life-threatening pneumothorax. So we have to catch these early. That's the reason why we tell you to auscultate and listen to the lung sounds as much as possible. It's basically what it's broken down to. It's in a vacuum-like pressure in the pleural space. It keeps the lung inflated, but when the surface of the lungs is disrupted, air escapes into the pleural cavity. So that's what causes this to happen. So something has to happen right in here, the area injury site, and creates all the vacuum to be displaced. So pleural effusion is a collection of fluid outside of the lung. It compresses the lung and causes dyspnea. Remember when we talked about that earlier? It can be caused by irritation, infection, congestive heart failure, or cancer. Will be decreased over the area where the effusion is present, and patients feel better if they are sitting upright, because there's nothing affecting the pressure upon their chest when they're sitting upright. It's a draining effect, basically. Obstruction of the airway. A patient with dyspnea may have a medical obstruction. In semi-conscious and unconscious patients, the obstruction may result of aspiration or vomitus of a foreign object or improper positioning of the head. It's caused the tongue to block the airway. So if the patient was eating just before the onset of dyspnea, always consider a partial possibility of a foreign body obstruction. Always look in the mouth. Again, we've told you before, please don't stick anything of your digits, your fingers, or that's not a medical device into their mouth. So the figures here show the obstruction of the airway of a foreign body. So let's see here. So food is the occlusion is right here. B is the tongue. As you can see back here, it has dropped and set back down into the airway. And that's what's occluding the airway. So both of these are obstructions, but this right here can be resolved by proper positioning of the head. So we want to make sure when we do positioning, and we can do the head tilt chin lift, that we bag them and make sure that there's good airflow. So pulmonary edema, pulmonary embolism. An embolism is anything in the circulatory system that moves from its point of origin to a distant site and lodges there, obstructing sequent blood flow in that area. So circulation can be cut off completely or partially. An emboli can be fragments of blood clots in an artery or in a vein that break off and travel through the bloodstream, a foreign body such as a bubble of air. A pulmonary embolism is a blood clot that circulates through the venous system and the right side of the heart and lodges in the pulmonary artery. Like yours shows, if it's large enough, it can cause sudden death. That is something that even if they were sitting on the operation table, we are not going to be able to fix. It is done and is over with. Sometimes it is not our ability to help save them, but we're going to provide them the best care that we can. So here's some signs and symptoms of pulmonary emboli. They do include dyspnea, tachycardia, tachypnea, varying degrees of hypoxia, cyanosis, acute chest pain, and hemoptysis. With a large enough embolism, complete obstruction of the output of the blood from the right side of the heart can result in sudden death. So if we talk about hyperventilation, we've all seen this at some point in time. Maybe we've had it occur to us or we witnessed somebody hyperventilating. And this is defined by an overbreathing to the point that the level of the arterial carbon dioxide falls below normal. This may be an indicator of a life-threatening illness, and the body may be trying to compensate for acidosis, which is the buildup of excess acid in the blood or body tissue. It can result in alkalosis. So this can cause symptoms of hyperventilation syndrome, such as a panic attack, and it's going to include anxiety, dizziness, numbness, tingling of the hands and feet, and painful spasms of the hands or feet, which is called corporeal spasms. The decision whether to hyperventilate is being caused by a life-threatening illness or a panic attack and should be made outside of the hospital. It should not, let me start that over. The decision whether hyperventilation is caused by a life-threatening illness or a panic attack should not be made outside of the hospital. That is something that is a higher level of care that needs to make that besides you or I. So we have an environmental or an industrial exposure. So we've all seen these plants here recently. They may have had fires, they may have explosions. Every plant has incidents. We don't want those incidents to happen, but they just do. Some of it is human nature. Some of it is just mechanical failure. So we have pesticides, cleaning solutions, we have chemicals, chlorine, and other access into an industrial site and inhaled by employees. So carbon monoxide poisoning, we know that carbon monoxide is an odorless and high poisonous gas. People inject a smell into natural gas. That's why we smell that, but we can't smell carbon monoxide. It is the leading cause of accidental death in the United States. Carbon monoxide is produced by fuel burning household appliances and is present in smoke. People who have carbon monoxide poisoning complain of a flu-like symptoms and even dyspnea. Do not put yourself at risk. High flow oxygen by non-rebreathing mask is the best treatment for a conscious patient. When we go to do a scene size up, usually standard PPE is going to be our ideal go-to for any type of EMS calls. If there are multiple people with dyspnea, consider the possibility of an airborne hazard material release. If a mechanism of injury or illness is in question, ask why 911 was activated. Why did you call us? What brings us here today? By questioning the patient, family, or bystanders, you should be able to determine the mechanism of injury. Should, not always will, but you should. So on our primary assessment, identify immediate life threats. We know we're going to address our ABCs and any other additional life threats. Form an overall general impression of the patient's level of distress. Note the age and position of the patient. Use AFPU scale to check the responsiveness and ask the patient about his or her chief complaint. We want them to tell us, not the bystanders. If the patient is conscious, let's try to hear everything we can from the patient. Also, we will take what the bystanders say, but sometimes we need the patients to answer their own questions so we can check their mental status, their history, what is the last thing they remember, going down our APU scale, our DCAP, BTLS, and our samples. We got to get all those done. We got to get them answered. So make sure that the airway is patent and adequate. Evaluate whether the patient is breathing, and the breathing is adequate. Is the air going in round and round and in and out? Does the chest rise and fall with each breath? That is super important. If it doesn't, they're not breathing. If the patient is not breathing adequately, you're going to see the rapid, shallow breaths. We know that that's not sustainable to life. Sorry. So here's how we're going to assess the breath sounds. We're going to take our stethoscopes. We're going to auscultate on the top side of each side and then right under the nipple on each side. That's how we're going to do the front side. Now we swap over to the back. We're going to auscultate in more areas. Again, 2 at the top, 2 at the bottom, and on the left and right. So we're listening to the left and right lung sounds here. We just have to remember we're doing it in 3 different places for the right and the left. We're just making sure that we hear the upper lobes and lower lobes, that we don't happen to hear anything else. If you listen down in here, that's the reason why they're not showing you on the front side. It's because you will hear gastric sounds. You're not going to hear the lung sounds on the front side. You will hear the gastric sounds of just the body's normal way of moving just stuff up and down the gastric system. So we're going to assess the pulse rate, rhythm, and quality, evaluate for shock and bleeding, assess the skin color, temp, and condition. If you notice, our primary assessments are going to be the same throughout each individual ones that we go through. So when we went over assessment, we wanted to pound in there that you know what to do here. We're going to check their circulation. We're going to make sure that their pulse is present, their rhythm is there, and they have a good quality. Again, we talked like we did last night, address your life threat and proceed with transport. Do we make this a rapid transport or do we stay in play? It depends on your decision on what you want to do. Now, again, it doesn't mean that if you say, okay, well, we're just going to go no lights and sirens. You can upgrade at any point in time in your transport. And at the same time, you can reach out for assistance. If you need air transport, you need a medic to intervene with you if you're on a basic truck. Those can be made during the decision of transportation also. So history, investigate what's going on. Why is the patient having problems? What has the patient done for the breathing problems? What is different for them to call you now? With patients in respiratory distress, always do a sample history, and that can be collected from the bystanders, the families, if they're present. If not, we're going to have to get that from the patient themselves. The OPRQST, it can be used to assess pain and gather information about the breathing problems. So here's a different one. So they're talking about using the PACE. PACE is an assessment, an alternative assessment for complaint of shortness of breath. So PACE stands for progression, associating, sputum, talking tiredness, or excessive tolerance, or exercise tolerance. So here, if they're, what is like their sputum? Do they have, I've never used the PACE method, but it is a very good algorithm. It's a very good way for you to remember how to assess their airway status. And it sets as their chief complaint for shortness of breath. Why? It's another way for us to remember how to assess these things. Yes, I know you're beat to death with abbreviations and just different things, but remembering your sample OPQRST is the most important part. These help out dramatically on improving our patient care. Our secondary system, that is only processed with secondary assessment of life threats and has been addressed and treated. We only go into our secondary assessment once our primary is complete and there are no more life-threatening issues. If we have a way to use, if you have a LifePak 12 or a Zoll or a LifePak 15, put those in place and let them go. Let them do their jobs. Let them give you the information that we need. So secondary assessment of COPD versus congestive heart failure. So look for signs of COPD. So any patient with COPD normally has all of these. They do often exhale through their pursed lips. And what I mean is like they're trying to whistle. So what they're trying to do is they put themselves in a positive pressure by breathing out a very small hole. And it keeps the pain from being as severe. And it's easier for them to breathe when they have their lips perched like that, so they can, it's a very audible sound when you hear them breathe like that. They do have some digital, when I say the fingers here, the digital clubbing, and this is an abnormal enlargement at the ends of the fingers. That shows that that is a sign of COPD. They do have or suffered from. Now, once you have COPD, it's always there. It could be mild or it could be excessive. So just be cautious in that when you're looking for your patient assessment, look for the clubbing of the fingers. Those are telltale signs. I repeat the primary assessment, determine if the patient has, if there have been changes in the patient's condition. This is an ongoing assessment to confirm your adequacy of interventions in the patient's status. Provide oxygen via non-rebreather mask at 15 liters, providing positive pressure ventilation using a bag mouth mask, pocket mask, or other powered devices during this time. Using airway management techniques such as a oropharyngeal, nasopharyngeal, we may be suctioning at this point, or we just have to do the airway positioning, the head tilt chin lift. So provide non-invasive ventilator support, as in CPAP. Now that is probably not going to be allowed in your protocols by most agencies. Depends on what part of the country you're in. It may let you, they may have some very aggressive. Texas basics are allowed to do a lot more than Mississippi and Louisiana. That's just because they are an aggressive state. I'm not knocking Mississippi or Louisiana, but we do need to move into the 21st century and try to get some more skills out there. We are going to position the patient in a high Fowler position, our position of choice. When we say a high Fowler, basically what I'm saying is that we want them in a 45-degree position, and it's going to be it mimics the seated position. We want them in the position of comfort. If they can't breathe in that position, then they can't breathe in that position. We need to sit higher, maybe into a 90-degree position. We want to assist the patient any respiratory medications, communicate all to the staff receiving hospitals. If we did something on the way in and improved it, let them know what we did. Let them know that, hey, this inhaler helped at this time. This is what the patient had. We gave it to them and improved it. It hasn't changed since we gave it to them. It hasn't deteriorated, but give them some background information. Management of respiratory distress, always provide supplemental oxygen, administer ventilatory support if the patient's mental status is declining. If there is a moderate to severe respiratory distress, or if the depth of their respirations are inadequate, provide oxygen, never withhold them. You always want to monitor the respiratory status. And remember, like I told y'all, that I like to get the patient to speak to me. That allows me to know that they're awake, alert, and oriented. We want to provide emotional support. Be that person that listens to them, checks on them, make sure that you understand that everything's okay and it's going to be better, or hopefully it's going to be better. Don't ever tell them that it's not going to be. If the patient has a metered dose or an MDI or a small volume nebulizer, ask if you can give that. Call med control and see if that's something that you can provide to them on the way into the facility. Ensure that there is no contraindications for the patient's condition. Is it going to hurt them if we give them this medication? So common side effects of inhalers are increased pulse rate, which we know that's going to do that. So they get a little bit of nervousness and muscle tremors. Some medications from an inhaler is delivered through the respiratory tract into the lungs. So look at your book and look on 16.1 to 16.2 to give you some ideas on self-administered inhalers and what to look for. All right, so treatment conditions. So when we talk about special conditions, we want to talk about the upper and lower airway infections. If we're able to, let's administer humidified oxygen. That's only if you're able. Some agencies don't do that. Do not attempt to suction the airway or place an oropharyngeal airway in this patient if you suspect epiglottitis, because it's going to inflame it, made it to start swelling more. Put them in a position of comfort, man. I don't really know the best way. If, like I told you before, if they want to ride with their knees on the stretcher and their butt up in the air and their chest on down, if it's comfortable to them and it's safely to transport, okay, do it. and we want to make sure we transport promptly. Let's get them to the facility as fast as we can, and make sure that they're there and they're receiving the higher level of care as fast or safest as we can make it. We want to provide supplemental oxygen 100% anytime you affect a pulmonary edema. You do suction if necessary, position in the comfort, provide CPAP, and that is only indicated by your protocols. If it is not allowed, then you can't do that. Even though you know the patient needs it, you may be able to call for a paramedic intervention, and they can meet you and give you that, they can give that skill. Now you will have to end up letting the paramedic ride in with you at that point, because that is a higher level of care, and they can't leave the patient once that's been done. Well, next. So COPD, if we're able to, and they have their medication with them, you always assist with their prescribed inhaler. And remember, it is an assessment, not as we're giving the medication, because remember, none of us have MD behind our name, so we're not able to do that. Position comfortably, again, transport. Asthma and hay fever, these are the same exact slides as is going to. Be prepared to suction, assist with the prescribed inhaler, provide aggressive airways management, and transport properly. Hay fever, I mean, it's the same exact slide. So the only thing that's different here is if you have to, for anaphylaxis, you can give the epinephrine. If they have their EpiPen on them, you can do an assist provision of giving that. Spontaneous pneumothorax and pleural effusion. So the difference really here, the pleural effusion can only have their fluid removal once they're in the hospital, but in spontaneous pneumothorax, we do want to supply supplemental oxygen, even though that we know that they have that air trapment. We still not going to hold the oxygen from them, but they need that because they're going to be short of breath. You have to monitor them very carefully right in here, because what's going to happen is they're going to crash on you pretty quick. If you recognize and you're able to understand and you know that they have that spontaneous pneumothorax early, I'm telling you to reach out and call for a paramedic intervention and or air transport. You're going to save that patient to life. It is okay to pass off a patient to a higher level of care because they have extra abilities that they can do. I will more than likely let a helicopter come get my patient. Whew, they can have them in a second. So any type of obstruction of the airway, so they break it down into 3 different parts. You have your partial obstruction, complete obstruction, 2, and then so partial and complete. Obviously, you can tell the difference right here, and you know what you're going to do, provide oxygen. These are going to be a rapid transport, even if it is a partial obstruction. And the reason why is because we don't know how vast that is into turning into a complete obstruction. So if you realize that something's going on, transport immediately, and that's lights and sirens there. When you talk about a PE, pulmonary embolism, we are again going to supply supplemental oxygen. That is a mandatory delivery, and there's a high flow of supplemental oxygen. If I have just, again, here with PEs, you recognize them. You have to be very, very careful with these patients because these PEs can move. So the last one is probably the utmost important, is transport promptly. Get them to that facility where they belong and they need help. So hyperventilation, that is completely primary assessment and gathering history here. We want to get that complete history obtained, know what's going on. Is this something that's happened before? Do we know that this is here? Reassure that the patient and provide supplemental oxygen. Just listening to them and telling them, hey, I need you to breathe slowly, talk very calmly, be very, assuring what's going to happen. And just telling them, hey, if you don't slow down, you're going to pass out. I need you to try to take breaths in your nose and out your mouth. A lot of times it will work, sometimes it won't, and they will pass out. And that is an auditory response where they just start breathing again on their own, and it's back to the normal. But that can take time. They can start using all the oxygen up in their body, and their fingers start deforming, and they kind of get all brought in. They just have that withdrawal. It's kind of like you're drawing all the water out. You just it's not comfortable. So environmental and industrial exposures, the business thing we can do here is make sure that the patient is decontaminated and supply as much oxygen as we can in a safe manner. If we can't get to them because it's unsafe, then we can't get to them. We have to leave them where they are until it is a safe for us to go to them or they're brought to us. Never, ever, ever put yourself in danger to where you're trying to gain access to a patient just because you want to save their life. It's not safe. A foreign body aspiration, perform the appropriate airway cleaning technique to the specific age. Heimlich maneuver, you can do the standing or seated. Tracheostomy diffusion, position the patient comfortably, provide suction to clear the obstruction. And once the obstruction is clear, always oxygenate your patient and transport on both of them for the foreign body and the tracheostomy. Because we need to have that checked out and make sure there's not any aggravation on the inside. There's not going to be any potential further swelling. And if it's swelling, we need to be able to get them to fix that. And that's something in the facility that can do versus us that's out in the field that doesn't have a lot of tools. So asthma for children, you want to provide a blow-by, which blow-by oxygen means hold the mask in front of the child's face. A lot of times these kids don't like these mask devices over their face, so you just have to hold it up to their face and allow it. If you have the particular meter dose inhaler that is made for children on your agency, then you can use those. Here for asthma, you can allow that the patient take their meter dose inhaler. And as with any chronic disease, asthma may be life-threatening and the older the patient is. So cystic fibrosis generally is a genetic disorder that affects the lungs and digestive system. It is a predisposed in children, repeated lung infections. Symptoms range from the sinus congestion to wheezing and asthma-like complaints. Suction generally and provide oxygen as needed. That is something that you can provide if they need, and you can give it to them. And if they don't really want to wear it around their face, that's okay. But you turn it down, or either leave it as a blow-by for the adults too. All right, so I appreciate y'all tonight. That is your class code for this evening. And it is 789-123. That's what you can get for your course attendance code. If anybody has any questions, concerns, or y'all want to ask or me to clarify anything, please put me a message in Discord and I will do my best to get to you in a timely manner. I hope all y'all have a good time, good weekend, stay safe. I will talk to y'all Tuesday. Just remember, Tuesday is my travel. I will be unreachable on Tuesday. All right, thank y'all so much. Have a great night.